We are delighted to be joined now by one of the fine folks from Oakland University. It's Jason Wasserman. He is an associate professor of bioethics at Oakland University. That's a pretty big business card as well, Jason. Thank you, and good to have you here on the MegaCast.
Thanks. We've bioethicists have been busy lately, as you know.
Well, yeah, absolutely. So, you are a professor at the Oakland University William Beaumont School of Medicine. I see your William Beaumont School of Medicine pin.
Yep.
Flying the flag today. Just as a starting point, as a foundation, we get it, but just definitionally, tell us about bioethics.
Yeah, so bioethics broadly deals with the moral dilemmas that come up as a result of issues of life and death. So broadly speaking, it can include all sorts of things like the environment and animal rights, but I'm mostly squarely in the clinical bioethics space. So we really deal with specifically the ethical issues that come up in the context of healthcare and specifically patient care.
So it must be a busy time right now. As it relates to the coronavirus, what has been crossing your desk?
Well, I think we've gone through some waves. So the first one was as we saw cases starting to surge, how are we going to make fair decisions about who gets resources if those resources become scarce? Of course, everyone wanted to avoid scarcity. We never wanted to run out of ventilators, and we thankfully haven't, although if we see a second surge, that's still a possibility. But we had to plan for the case in which we might. And when you have one ventilator and two patients who need it, it's a very challenging ethical issue to decide who you should give it to. It's a decision that no one takes lightly. As we talked about how to plan for that, I think the moral weight of it was on everyone's mind. But it's a situation of a forced choice, and you have to make a decision. And then the question becomes, how are you going to make that fairly? What are the criteria you're going to use to make a fair decision, and what criteria should be off the table because they're unfair? That was the first kind of set of issues that we dealt with, and then we moved a little bit more into issues of moral distress among the staff as they were becoming overwhelmed at the hospitals, as we experienced PPE shortages and those types of issues. Those are ethical issues as well, how we treat our healthcare workers. And I think more recently we're moving into more questions about how we distribute these new medicines and how we inform people who might be taking them about them, given that they're new and data about them may be a little bit sparse. So remdesivir, for example, is in relatively short supply, but hospitals are starting to get it. They don't have enough for every patient. How do they decide who gets those medicines? And then how do they tell the patients about the potential side effects of that medication when there frankly just isn't a whole ton of data behind them yet?
Yeah, well, that's a boatload that you just dropped on us. Dr. Jason Wasserman, Associate Professor of Bioethics at Oakland University, and you're right. So we got through the initial resource crunch with the vents and the PPEs and the other things, but we have a big resource crunch ahead of us. You talked about the therapeutics that are out there. There clearly are not enough for everybody. Big challenge. And then here's the next one, vaccine. So we are racing to a vaccine, and we hope that we get a vaccine developed. But getting it developed and then getting it manufactured and distributed to the world, that is a whole other story. We're going to have folks like you that we're really going to count on for advice. If you are a little bit cynical and you look at our history, I think you would say that the wealthy and powerful will probably be at the front of the line.
Yeah, I mean, the policies we put into place are supposed to protect against that, right? So we talk about, for example, legitimate versus illegitimate differences. And typically speaking, for healthcare issues that are healthcare resources that are matters of life and death, ability to pay should never be a determining factor in who gets a treatment. But of course, the realities of the American healthcare landscape certainly find wealthier people able to access more care in all sorts of different ways. I would hope to see policies developed that mitigate that to whatever extent is possible when it comes to something as basic as a vaccine is essential to public health, particularly because many of the essential workers on the front lines are not among those wealthier brackets. And they may, I think, have maybe a stronger claim from a public health standpoint. But as you point out, inequality is a rather permanent feature of American society, and I wouldn't be surprised to see it leak its way into those decisions.
Well, we hope not, but I think we've done a pretty good job actually making sure that first responders and those on the front line are getting access to things first. You know, we all get a little frustrated when we go to the grocery store, and less now than maybe a month or 2 months ago, and you see someone wearing an N95 mask, and you just think, well, are they really a doctor or a nurse? You know, or is somebody putting their own priorities ahead of the medical community? We really hope that doesn't happen, and I would say by and large people have done a really good job. But, you know, you, Dr. Wasserman, and others all take this Hippocratic oath to make sure that we are serving people in the best interest. And you know, you guys do a great job, but there's a lot of ethics involved and the political side, and you know, we don't have enough hours in the day to talk through that one. But it's good that you're watching that. Is this, you have a program then at Oakland University where students are engaged in this whole process?
Yeah, absolutely. And just to clarify, I'm a PhD, so I've actually never sworn to the Hippocratic Oath because.
All right.
But I will tell you, at our program at Oakland University, I direct the bioethics thread of our curriculum for medical students, and as part of that curriculum, our medical students actually write their own oath that they swear to at their graduation, along with all of the people in attendance, many of whom are physicians, which is amazing to see, because what they're able to do is carry forward those hallowed ethical commitments that you just mentioned, providing the best patient care possible, putting patients first. But they're also sensitive to how the landscape of healthcare has changed since those oaths were really formulated. Even though they've been updated recently, the foundations of many of those oaths, like the Oath of Geneva, really date to just after World War II. And my students are always amaze me when they come up with these new and interesting things that they're concerned about. One of which, for example, is interprofessional teamwork. They have written into their oath over the last few years commitments to treating other members of the healthcare team, like nurses and respiratory therapists, with dignity and respect and collaboration, which is not something in the oath. So I have working with these students every day gives me a lot of faith in our future.
Well, always. When we work with young people, I would say the same thing. The young people now that we have the pleasure of working around amaze me every day. But I like what you're doing. I think it's fantastic. And, you know, we always learn something that we didn't expect to learn on this show. Today, it's that oath. I mean, the oath that we just stumbled upon talking about that your students are taking. It got me thinking, maybe, you know, we as a society should go back to a little bit of JFK, ask not what your country could do for you, but what you could do for your country. Maybe it's time that we as individuals all take the oath, whether we have raised our right hand and put something down on paper. I would suggest, Dr. Wasserman, and I'd like your feedback, that people have done pretty good. You know, we've done pretty good. We got things flattened out. There's a couple of idiots out there that are misbehaving, but, you know, for the most part, when I go to the store, I see people wearing masks. I see people social distancing. I think, you know, for the most part, people have taken the oath. Your thoughts?
Yeah, I agree with you. I think you know, a lot of times what we latch onto in our society are the margins and not the massive center. So we kind of we want to hear on the news about the extremes. We have this kind of predilection for those kinds of stories, but I think the average person takes the pandemic quite seriously. I do think it's challenging for any of us to really comprehend it and to comprehend what to do, because the data does change, and that's just the nature of an emerging infection. But it does challenge us in terms of, you know, clarity about what we should do. But I think people are by and large doing their best.
Jason Wasserman is with us, Associate Professor of Bioethics at Oakland University. And Dr. Wasserman, one of the things that we've been talking about for several weeks right in your toolkit is what's going on with the African-American communities. We have seen just a huge impact on COVID-19 on our communities of race here in Metro Detroit, and maybe that's one of the reasons our numbers have been higher than the rest of the country. Any thoughts on where we're at, what we need to work on in that area?
Yeah, well, the emerging data is pretty striking. As of May 15th in Michigan, where we have a 14.1% Black or African American population, that group is experiencing 32% of the overall cases and 40% of the deaths. There's a lot of social factors involved in that. Residential segregation that has persisted long after the 1960s and 70s in effect. Is one reason for it. Residential density is not equally experienced by all groups, and some of that owes to race and ethnic segregation in the residential sector. But then there's also lack of healthcare access, lack of access to physical activity opportunities or healthy foods. These things are also distributed unequally and therefore disproportionately affect certain race ethnic groups in our society. And those predispose people to the kinds of comorbidities that really complicate COVID. So, for example, hypertension, obesity, and diabetes are three very significant comorbidities that complicate and make one more susceptible to COVID and the effects of it, make one more likely to suffer an acute version of the disease. And these comorbidities are higher among the African American population for reasons that have to do with structural inequalities in our society.
Well, it may be, if any good has come out of this, the greater awareness of those problems in our communities here, in the African American and other minority communities. It has raised the awareness. It tragically has raised the awareness, and maybe we can, at some point, start working on that. We have an awful lot to work on right now, but we'll add that one to the list. Thank you for being with us. I appreciate this. Did you want to add something?
Oh, well, yeah, I just, in keeping with your point, one of my biggest worries and maybe one of my biggest hopes is that after COVID, we don't forget about these types of disparities, because these are not disparities of COVID. They're disparities of almost all illnesses, and they'll be with us long after, hopefully, we surpassed the COVID crisis.
Well,
Thank you very much.
No, it's good to have you on here. I didn't really think about that before this came up. To tell you the truth, Dr. Wasserman, I don't really think I thought much about bioethics very often. So you're in the limelight. We appreciate you coming on. You make Oakland University proud. Thank you very much for being here. I appreciate your time today.
It's been a pleasure. Thank you so much for having me.
All right, and we'll have you back again. He is Dr. Jason Wasserman, Associate Professor of Bioethics at Oakland University. And Dr. Wasserman, if you wouldn't mind, we have our COVID-19 vocabulary, and we put interesting things that come up on this show. I'm going to add, we like COVID foot, facial covering displacement. That's when your mask is not on your face. Non-dominant hand came out of another interview. As you know, you're trying to be careful which hand you're using. I'm going to add the COVID-19 oath today, and maybe we can get some people thinking about taking an oath and doing all they can, inspired by you. Thank you very much, sir.
I appreciate it. Thanks for having me.
All right.